Hello, everyone. This is Chris Sosa with Becker's Healthcare. Thank you for joining us for today's webinar, Roadblocks to Scaling Electronic Prior Authorization and How Leaders Are Moving Forward. Before we begin, I will walk us through a few quick housekeeping instructions. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. If at any time you have issues with audio or visuals, please try refreshing your browser. You can also submit any technical questions into the Q&A box, as we are here to help. With that, I'm pleased to introduce today's speakers. We have Stephen Burko, Senior Advisor on Value-Based Care for InterSystems, and Jessica Jowdy, Manager of Healthcare Sales Engineering for InterSystems. Collectively, they have a half-century of experience in the healthcare sector. Thank you, Steve and Jessica, for being here today, and I will now turn the floor over to you to get us started.
Thanks, Chris, and I want to thank everybody for taking an hour out of their day to talk about what's needed to scale electronic prior authorization, or EPA. And as Chris mentioned, both Jessica and I hail from InterSystems. So I just wanted to acknowledge up front that we do bring a little bit of bias to the conversation. So for those of you who aren't familiar with InterSystems, we're a global leader in health data management. We have special expertise in integrating clinical data from disparate sources. And if you look at the slide, you can see right in the middle, we have a lot of health plans that we serve as customers. So not surprisingly, we have a full solution suite for automating prior authorization. So we definitely have a bias towards technology, but that bias is not towards any specific segment of the healthcare market. If you look at the whole slide, you see that our technology is used by virtually every key player in the healthcare space, which we have actually found to be very, very helpful when we are figuring out about how to push forward in terms of electronic prior authorization. Because in contrast to the other APIs in CMS 0057, so the piece of regulation we're going to talk about a bit here, the access APIs are more, a one-time sharing of information, whereas prior authorization really requires an ongoing conversation, a back and forth. So we've found it helpful to be on all sides of that discussion. Anyway, enough about InterSystems. Before we go forward, I do want to look back for just 1 second in terms of prior authorization. Now, we're not going to look back too far. We're just going to go back to the beginning of last year. And on the left is kind of a reminder of kind of where things were at. So a lot of stuff in the popular press, and in general, I think health plans really being put on the defensive in terms of what is going on prior authorization. I think what's really interesting is how the federal government responded to that. They did not come up with a set of rules specifically, must do certain things with regard to prior authorization in terms of just directly. Instead, they mandated investment in interoperability. And for those of you who are wondering what is that jarble of language, this is actually the cover page in the Federal Register for CMS 0057. In the middle, you can see that familiar language, advancing interoperability and improving authorization processes. So again, a pretty interesting response. The federal government giving a huge vote of confidence for interoperability and saying, look, what we're going to mandate here is investment in the needed technology to streamline the process. And, at 100,000 feet, everybody, not everybody, but most people that we talk to are kind of on board with this vision, which I've tried to capture in one slide here. In the middle is really where most of the 0057 mandates fall. And what that regulation does is, in effect, saying we're going to pull prior authorization into kind of the modern structure of how finance communicates, how travel communicates. We're going to require that payers actually invest in the needed APIs to streamline the flow of information or democratize the flow of information between providers on one side and health plans on the other side. Now, if you go over to the left, there was a companion regulation that was calling for a mirror set of APIs. And it's important for everybody to keep in mind, I know it's a simple distinction, but everybody to keep in mind that we're talking about APIs. We're talking about exposing endpoints where people can, in effect, dial up and get the information. We're not actually talking about the application or the GUI, the user interface. But there was another regulation that was calling for a mirror set of APIs on the provider side that was not finalized. However, we're seeing a tremendous amount of energy now on the provider side in terms of, who can play the role of intermediating that conversation between the plan, APIs, and the EHRs so that the plans don't have to go individually to each provider in their network and connect things up. And over on the right side, tremendous amount of energy in effect, the health plan back office to say, how can we automate the conversations between all these systems needed to process a prior authorization request or to take advantage of those APIs that 0057 is mandating be stood up. And, sticking at 100,000 feet, it is really interesting that I've been doing a good amount of traveling lately, and pretty much everybody who I talk to, as at least in theory, is very, very bullish on EPA or automating prior authorization. And this is just my word cloud of all the things I hear from different people across the healthcare spectrum. Even if you start to move to pilots, there's been a growing number of what I call point-to-point pilots. So a pilot between maybe one plan and one provider that has been able to achieve pretty compelling results that are usually expressed as the number or the percentage of prior authorization requests which weren't even needed. In other words, the quick response was, this CPT code doesn't even require prior authorization, no need to go forward with this submission. I think the tough part is, as people have tried to scale this from a point-to-point pilot to a many-to-many solution, we're not getting the lift that you would typically see when there's so much general support and at least the preliminary pilots, there's so much positive results to share. And this is really what we want to explore across the balance of the hour. Why are we kind of struggling to kind of really, scale to those many-to-many solutions, and also to share some of the best next steps that Jess and I have seen being put in place by market leaders. Now, game plan to do this is basically 4 components, about 10 minutes each. We want to spend about 10 minutes just doing a primer on the provisions of 0057 related to EPA, about 10 minutes sharing kind of what we have gleaned from these kind of group root cause exercises we did in roundtables across the country, about 10 minutes sharing some of the lessons we've seen that we think are beginning to work in terms of scaling EPA, and hopefully that will leave us with about 10 minutes for Q&A at the end. So I'm going to keep moving right along with the hope that we're going to preserve as much time as possible for questions. So this is my best effort to reduce that 1,000-page regulation down to one slide on key provisions related to prior authorization. And I just want to be sure that as you scan this, that you walk away with 6 key takeaways. And the first one is really suggested by the subtitle, Requirements and Recommendations by Effective Date. It is very important that when people are throwing out provisions of 0057 to you, that you ask, is that required or is that recommended? Because there are both in 0057, and some of these timelines are getting awfully near, and it becomes a lot more doable when you recognize that some of the things that 0057 are calling for is recommended, which gives us the leeway to stage that in a more strategic rollout. All right. I know some of you are probably beginning to drift over to the right side, the tech provisions and the Jan 1, 27 implementation deadline, but I do want to pull you back to the left side and the timeliness and reporting provisions, because they are really right around the corner right now at the very outset of this year. So let's move on to key takeaway number 2. And this regulation is relevant to impacted payers. And at the risk of oversimplifying things, impacted payers are pretty much every type of payer other than traditional Medicare and commercial payers who are not on federally funded exchanges. I also, though, think it's important for health plan listeners to note that even though you got to start off with your impacted products, you want to be sure that you're building out solutions that can scale to all product types for 2 principal reasons. One, we are seeing a growing number of states already begin to pick up the language of 0057 and expand it to the commercial market. And 2, there's just increasing business pressure that this is right answer. And ultimately, we want one workflow for all product types. All right, let's go on to key takeaway number 2. And that has to do with the response timeframes. So for those on the line who hail from more the IT or the interoperability house as opposed to the utilization management side of the house, I know I've been sitting with some people, and sometimes people are like concerned, like, wow, suddenly there's these what look like hard and fast timelines for processing prior authorization requests, 72 hours for expedited, 7 calendar days for standard requests. I think what's important for everybody on the line to know that these are worthy goals, but not overwhelming goals. As a matter of fact, a number of the plans that I work with, even long before finalization of 0057, these were their worthy goals. So in effect, the regulation is more picking up kind of goals that the industry was already moving towards, as opposed to dramatically pushing forward. So again, makes it a little bit more doable. And if you're still concerned, it's important to note the next bullet down. There's no mechanism for auto approval if the payer exceeds the deadline, which brings us to the next key takeaway, which is reporting. That's really the stick here. If you don't meet these goals, there's various different things you're going to have to report on prior authorization performance. And the important thing to note here is that this kicks in on the 1st of 2026, so pretty darn soon, but actually the clock has already started running because you're going to have to report on the prior 12 months. All right, let's go over to the right side and the tech provisions. So now we're moving from an effective date of 1st of next year to the 1st of 2027. Still pretty fast considering how much technology has to be put in place and workflows have to be changed. But the next key takeaway has to do with the payer APIs, and it brings me back to that required versus recommended delineation. What the rule requires is that plans stand up APIs that accomplish 3 things. Can respond to the question of whether prior authorization is required, can identify the specific documentation required to adjudicate that prior authorization if it's required, and can, in effect, facilitate or process a response. That's what's required. Now, what's recommended is that health plans accomplish this by following what are called the 3 Da Vinci implementation guides or burden reduction IGs. And let me be clear, we are huge proponents of Da Vinci. We are longstanding members of Da Vinci, and everything that we do is in accordance with Da Vinci. But again, for people on the line in terms of figuring out how are we going to scale, I think it is important to recognize that there's certain things we must do by January 1, 2027, and there's certain things that we can stage at a logical time frame for how we're aspiring to build this out. Now, for those who are noting that everything I've talked about so far has to do with a pay or a health plan requirement, yes, that is true. 0057 overwhelmingly involves plan mandates. There is one requirement, however, with regard to providers. It's down at the bottom, and it does require that providers, again, oversimplifying here, that are participating in federal programs, attest, yes, once a year, that they have utilized the EPA process. So to be clear, it's basically a yes or no. There was discussion at points about whether people should have to disclose a denominator and a numerator, and at least that was pushed down the road. So the bottom line, at least right now, as we build this out, if we want to scale, we have to be sure that we are building a bridge that providers want to cross. All right, with that, I am going to turn it over to Jess to dive a bit deeper on the recommended IGs. And I will note, these are strongly recommended in the regulation.
Fantastic. Thank you, Stephen. So for those who have become acquainted with this regulation in a bit more detail, these acronyms might be familiar to you, but these three acronyms represent the three implementation guides that are highly recommended as part of the EPA portion of the regulation. You have your CRD, your coverage requirements discovery, your DTR, your documentation template and rules, and your PAS, which is your prior authorization support. In a second, we'll walk through kind of a workflow of all of this, but just at a high level, each one of these has a specific task that it's granted. So our CRD is really in charge of determining whether a prior authorization is needed for a given service. This leverages the CDS hooks paradigm, so it's leveraging an already existing standard for being able to integrate with provider systems and grab that triggering event. Your DTR is all around fetching documentation. So given in the previous step that a prior authorization is required, your DTR is going to share the documentation, questionnaires, and other information required when you submit your prior authorization request. And then your last IG here, your PAS or PAS, is really in charge of doing the formal submission of your prior authorization request with the relevant documentation included. And then in addition, there's your subscriptions and notifications to keep the providers in sync or in the loop as that prior authorization moves through its processing pipeline. And so just to put kind of a flow chart to some of this, we'll break down the CRD process, and then we'll go to the PAS or the DTR and the PAS. But starting with the CRD, these processes are instigated by the provider systems. The intention is for that to be driven through the EHR, through native workflows, which is why CDS hooks was one of the key factors in this IG. So the idea here is within the provider system, by leveraging the CDS hooks on a particular action, we enter into the CRD process. Now, the CRD process would include information on determining whether or not a prior auth is required, which includes contextual information that the EHR has about that particular event, like the patient that's in context, the service, coverage information. There might be a situation where additional information may need to be provided in order to make a determination as to whether or not a prior authorization is required. So you can almost think of that as like a loop back, if you will, where we can call back into the EHR, supplement the information, and then launch back into that CRD. Through the rules that are used to determine whether or not a prior authorization is required, I will get a determination back through the CRD process, whether or not a PA is required, maybe an auto approval, or if more information is needed, in which case we'll go into the DTR process. One of the interesting things about leveraging these CRD and CDS hooks is that it leverages through the CDS hooks paradigm this concept of a CDS cart. And these cards can share information not just as to whether or not a prior authorization is required, but it also has options for supplying additional information back directly in front of the provider system. So suggestions based on the information that you know about the member. So it's a nice way of also being able to provide additional information back to the provider about information that you as a health plan know about that member. So we go through our CRD process. We determine that a prior authorization is required. This brings us into the DTR process. Now, the CRD kind of launched really meant to be very much automated. It's using machine readable rules. And so that's really the context for all of these different IGs is making things automated, machine readable. So bringing that into the DTR process, this is all about getting those provider systems access to the documentation needed to support a prior auth submission. And so this could be commonly like questionnaires, documentation. Now the questionnaires that we're seeing, really entering the space are really built to, there are ways, I should say, that can reduce the burden on the providing system or the provider system to supply the information needed to supplement the questionnaires or the documentation. And that's where this concept of CQL comes in. So overall, right, the idea is burden reduction, right? And so with these questionnaires, one of the options that you can have is to embed CQL into the questionnaires to pre-fetch information from the provider systems and answer these questions. And so we see that in these initial steps with CQL included, we can do that kind of pre-population and provide to the provider systems a partially completed or maybe fully completed in situations where all the information can be obtained through CQL piece of documentation. We can then query for any missing information and then show that documentation in the context of the EHR for the provider system administrator to be able to complete the missing information. In this process, for those pieces of information that might not have been pulled from CQL, they can move through that. They can save that documentation as they work. That's saved locally into the EHR until it's ready to be submitted as part of the final pass process. There are options for things like adaptive forms that allow us to almost build a questionnaire on the fly based on responses to previous questions. And so there's this kind of concept of having a decision tree, if you will, of questions based on the content. So once we have finished this DTR, once the content has been put together, we submit our PA request through the pass process. As part of that, we mentioned these metrics that Stephen had referred to. We're capturing not only determinations, but other kinds of metrics that need to be reported as part of that 2026 deadline. And then there's that subscription piece as well. So providers can be notified actively, or there's a polling process where they could pull information as to the status of their prior authorization. And then finally, while not required for the regulation, we do see value in the CDEX implementation guide in the prior authorization process for being able to actively pull information from the provider systems to supplement the information that the health plan knows about the member. So now, not required, but we do see a lot of value in creating those CDEX interactions between the provider and the health plan. And then just at a really high level, when you put all of these things together, this is kind of a highlight level diagram. I'm not going to go into a ton of detail, but you have your provider systems, you have your health plan systems, you have your IGs that kind of orchestrate all this call out. And then what's kind of necessary through this process, as you guys are probably putting together, is some kind of orchestration layer, interoperability layer that's able to integrate with all of these different systems on the back end side, because as we know, all three of these different interactions require working with any number of different vendors, applications, and systems. So we really see the need in having that layer and then letting that serve as the interaction point for the CRD, the DTR, and the pass process. So I don't want to go into too much detail given time, but we see that being incredibly valuable. And before I turn it over to Stephen, we did put, back over to Stephen, I should say, we did put or aggregate a lot of this information together in a white paper that you are welcome to download. The link is right here. You can visit our website to see it. And it's really goes into the nitty gritty of these regulatory requirements, prior authorization, as well as the other aspects of the regulation. Highly encourage you guys to download it, take a read, and I think there's a lot of valuable information there. So with that, we're going to switch gears a little bit and go into the next section of our presentation, which I'll turn back over to Stephen to kick us off on.
So thanks, Jess. So hopefully 2 takeaways from Jess's remarks. Number one, there's a lot to do and in a limited time, but the other takeaway is it's doable. So we really wanted to spend some time kind of doing our own little learning journey to better understand what's holding the industry back from kind of starting to scale. Because, I mean, that's the ambition. This is going to be too costly and not worth the effort if it just winds up with a pile of point-to-point solutions. So across this past spring, we held a series of roundtables. All told, you can see we had 59 participants from plans and providers. I want to acknowledge up front, we started this on the plan side, so it tipped dramatically towards plan participants, 45 plan participants, but then we decided we should talk to some providers as well to see how they see things. At the outset of each of these roundtables, what we asked, we gave participants 3 dots, and we asked them to plot those 3 dots on what they saw as the 9 biggest barriers to scaling EPA across 4 technologies. And, you know, all told, that left us with well over 170 plotted dots to construe. And on the next slide is kind of the top line finding. And, you know, what I'm doing here is comparing kind of the dots plotted by the plan leaders versus the provider leaders. And, you know, I think some good news here, you know, there's sometimes been so much tension between plans and providers, but there's actually a lot of commonality in terms of how plans and providers are seeing the challenge. And I know the sizes of the boxes are a little bit different, but, you know, it's pretty much spread across all 4 categories. And also keep in mind that our N for the providers leaders is relatively small, so the data is a bit clunkier. Actually, I think if you move from the general categories down to the individual barriers, you really begin to feel that there's a lot of commonality of perspectives across plan and provider leaders in terms of kind of what we really need to get out in front of if we're going to scale EPA. And so, you know, on both sides, you see a lot of color. So, you know, all 4 larger categories. But if you go over to the provider side and then you crosswalk it back to the plan side, you can see that 4 of the top 5 on the provider side are also among the top 5 on the plan side. I think, ironically, the most important takeaway, if we're going to bridge this gap, is the one thing on the provider side that was not elevated on the plan side. And I will tell you all that actually there was not 1 dot placed on insufficient evidence of quantifiable concrete ROI by any plan leader across all roundtable sessions. And I think this is really important because, you know, I referenced up front the successes that have been on pilots. And again, commonly the quantified result that is kind of advertised is, you know, 50, 70, over 80% of submitted PA requests, the response back, no PA is required. And when you're moving from numbers to actually just qualitative discussion with providers, can I ask them, why isn't that like really exciting to you? And the answer I often got back from the provider leaders was, well, you know, we're going to continue to probably submit most PA requests, at least for the short to medium term, even if we think they're not required, because we want to document that. And so I think that they don't see as big a savings as that coming down because they intend to increase those. And I think what the provider leaders are really looking for is actually how much time is saved largely in the back office by streamlining the prior authorization process. All right, where real differences began to emerge is when we cut the plan data by actually plan leaders in IT versus clin ops. And looking at this, you can really see that the way that the stack bars, I mean, they're almost inverse. So you have the plan IT leaders kind of saying like, what's really in the way here is we have all these other things we have to do, and we're struggling to get the rest of our organization on board. You flip it around and you go talk with the clin ops people, and less concerned, shall we say, about the competing priorities their IT colleagues are facing, and more concerned about, what, I know you guys on the IT side are saying we've got answers for how to deal with the legacy technologies. We increasingly have standardized formats, but over here, I have less confidence that we're going to be able to clear those hurdles. Good news is, though, again, when we go down to the individual element level, we do begin to see more commonality. So specifically, the top two, aversion to changing existing workflows and siloed systems for related functions that don't talk to each other. Those were the top two for both. And also, remembering back to the providers, siloed systems for related functions, that was number one among providers. And I believe the aversion to changing workflows was number 4. And those two account for 30 to 40% of the plotted dots for all three groups. So there are definitely, kind of some, it's not all just a gazillion pebbles. We've got some definite rocks here that we have to account for if we're going to scale. And I think when you push forward, you always want to be thinking about how are we getting people who are going to be impacted by this change in workflow on board? And we want to be sure that everybody sees how those different systems are going to be able to talk to each other. Now, below the line, you can see real differentiation on the left. Then you can see plan IT leaders really getting much more fixated on the competing priorities, all the other things they have to do, where again, on the right side, the ClinOps leaders having more concern about how are we going to deal with all this, the unstructured data, all the different formats, how are we going to have to deal with that old adage that they're really feeling that healthcare is data rich, but information poor. Now, before we go on to some of the things that we've seen that we think are at least beginning to overcome some of these barriers, I do want to just do one slide looking at the other end of the spectrum. So these were those tested elements challenges that got only 1 or no dots among plan leaders. So I am staying on the plan side still. And I also think there's some good news here. I want to focus everybody on trust for a moment. Kind of at the outset of this process, as I was working with different plans, there was a tremendous amount of concern about whether the low adoption rate of precursors, so the 278, 275 EDI process for prior auth, or the 9115 patient access API, lots of people saying, I'm going to struggle to get my organization to invest because we've been down this road before and we haven't had the take-up that we were hoping for. Actually, again, with regard to EPA, doesn't seem to be a big barrier. Again, specifically focused on EPA, not the other access APIs. And when I talk to people, it's that word cloud again. People realize that we've got to get there, that all sides want to see the benefits of EPA. Also, at the outset, a lot of people fearing that legal concerns around information sharing might hold us back. That not popping, at least in our roundtables. The other thing, again, I want to call out is insufficient evidence of quantifiable concrete ROI. I don't think this should be here. I think we, on the payer side, have to begin to recognize that we've got to get beyond the metric of simply the number of prior auth requests for which no prior auth was needed. That's a great measure, but we need to also move on to measures that actually show the efficiencies providers will be able to gain by moving to EPA. So that winds up our kind of quick takeaways from the roundtables that we did. We definitely wanted to preserve some time for the lessons that at least Jess and I are gleaning when we're out there working with market leaders, particularly leading health plans, in terms of some of the things that we would encourage everybody to start to do. And I think we got a total of 6, and Jess and I are going to split them. So the first one, expand your mapping of current PA processes to include impacted systems and people and common workarounds. So typically when Jess or I go into an organization, one of the things the organization rightfully wants to do or has already started is to map out how they want the new process, the electronic process, to work. What we're seeing in terms of best practice, however, or maybe I should say emerging best practice, is sometimes we'll walk into a place and the health plan will have spent a lot of time really mapping out with both IT and interoperability and UM all in one room, how does the current process work, including impacted people and those common workarounds that all too often people don't want to talk about. And this is really important for 2 reasons. One, again, we mentioned one of the biggest roadblocks is these siloed systems. And all too often when people do the mapping of how the process currently works, they surface systems that are being impacted that sometimes are forgotten, shall I say. And the other thing is, ideally, you expand this map to include impacted people and common workarounds, because let's not forget what's the other big barrier, the aversion to changing workflows. So very important to know upfront, who are the people who are going to be impacted by this change in workflow, and what's their pinch points? What are the common workarounds? Because if we're going to want to get them on board, one of the best ways to get them on board is to show them how EPA will better address those workarounds they're currently struggling with. Jess, you want to do 2?
Yes. So for our second one, keep what's required versus recommended by CMS 0057 top of mind when staging a rollout of EPA. So we've already kind of discussed this in a little bit of detail when we're talking about those implementation guides and the recommended or highly recommended path by which prior authorization, this electronic prior authorization, should be implemented. One of the other kind of aspects beyond just the how of creating the APIs that I would touch on in this particular kind of concept or lesson is almost like a scope creep kind of conversation. When we have the opportunity to reduce burden and kind of do something revolutionary, which I think EPA is quite revolutionary in its goals, we tend to try to boil the ocean. And it's important for us to stay grounded in, what do I need to do by 2027? And for instance, I think a lot of folks are even evaluating, can we make everything electronic? Can I get rid of all of the other ways that I do prior authorization and drive everything through EPA? I think that's our goal, right? But you don't have to do that on day one. So create a plan that allows you to evolve. That could be evolving to include other lines of business. That could be evolving to consolidate your pipeline so that everything runs through a standard framework. But just be mindful of what needs to be there on January 1 versus what your ultimate business goals are with EPA going forward. For our number 3, invest in a high-performance API manager and data integration engine. For me, I think this is one of the most important items or lessons to learn. When we think about EPA, I already kind of discussed this in a bit of detail during this earlier slides, but there is a need for high-performance orchestration and integration to connect the initial provider systems that are requesting or passing through the prior authorization request to all of the back-end systems within a health plan, or maybe even outside of a health plan in terms of external vendors that you might be integrating with as well. And that entire process is going to be somewhat unique from health plan to health plan. So being able to take the implementation guide or the standard that's been kind of proposed as the highly recommended approach and tailoring it to your back-end needs is critical. And having a high-performance integration engine, a highly flexible integration engine, acting as that kind of middle layer or that orchestration layer between the two is almost a necessity, in my opinion. The other piece of this, the API management layer is critical in this. So we talk about, expanding for all of the regulatory requirements of this, of 0057. The load on the API side is going to be much higher than in previous years, right? We're now expanding beyond patient access. We have all these other APIs. So having a high performance API management layer to be able to satisfy those inbound requests and have highly performant response times is also going to be critical. That's going to help with your adoption of these APIs.
All right, number 4, focus first on leveraging your 80/20s to capture efficiencies from digitization of medical policies to plan provider communication flows. And this is in some ways the corollary to Jess's lesson about keeping in mind what's required versus recommended. What we see is if you're trying to do kind of 100% of your aspiration out of the gate, that can be a really, really tall order. But if you back off maybe to just aspire to do 85% or 90% or 80%, that's really doable. And, just in terms of change management, it's good to get some wins and then to keep going. So one of the ones that I think where word is really getting out there in the industry is up front, there was a tremendous concern about, wait a minute, if we're going to move to EPA, does that mean we have to digitize all of our medical policies across all the different rule sets and vendors we use right out of the gate? Absolutely the right aspiration, but you don't have to do that all by January 1, 2027. Instead, look for your 80/20s. Every plan that we're working with reports back to us that there is an outside number of CPT codes that account for the larger share of the types of prior authorization requests. So you should look for those 80/20s and start with the ones that are accounting for the outside share. You might even want to split it again. Look at that group, and if you have limited bandwidth, go for the ones that large share of prior authorization requests and most ready to be digitized. We're actually now beginning to see it actually on the other side in terms of scaling or moving to multi-point solutions between the plan API and the provider. Again, at the outset, plans saying like, wait a minute, how are we going to connect up with every provider in our network? That is overwhelming. And the aspiration, could we contract in effect with one hub that would maintain the relationships with all the providers? We are not there yet, but in the last couple of months, increasingly working with plans to recognize maybe we can't get down from thousands to one, but maybe 3 or 4, whether it's a native capability within an EHR, whether it's an organization playing a partial hub role. Increasingly, it's looking like you can go into a relationship, a contractual relationship with maybe 3 or 4 entities, and then reach 80+% of your panel. All right, next insight. Apply proven tenets of change management, meet key stakeholders where they're at, and rely on trusted influencers to bring their peers along. I think the best way to illustrate this is to talk about where CRD actually sits in terms of the actual relationship between the provider and the patient. So ironically, on the plan side, again, this great aspiration that we want to get this so streamlined that a provider can be sitting with their patient, query the system, and get a real-time response back, whether provider authorization is required or not, and then use that real-time response to actually inform what sort of care is being recommended. Again, absolutely the right aspiration. We absolutely want to get there. But it's interesting, when I go over and I talk with the providers about how do they see the rollout, they ironically, again, nobody's monolithic, but in general, they ironically are saying, we don't want to nor need to start there. For us, we're probably going to keep prior authorization still in the back office because we don't want to roll it out to the point of care until it's been totally debugged. However, we are really, really eager to use it because our back office people are incredibly pressed. And if we can get efficiencies with them, we will travel this path. So from a technological standpoint, doing something in real or even near seconds is a lot more harder than doing something in 15 or 30 seconds, which basically my conversation on the provider side would be very, very meaningful. Again, as a start point, let's start there. Let's get some champions on the provider side, and it's those champions who are going to bring along the other providers. I think I'm back to you, Jess.
Yeah, for our final one here, ensure you don't have to ask providers repeatedly for clinical information previously shared. And some of this actually bleeds a little bit into the other aspects of this regulation. But we have this opportunity with these APIs to consume data that's coming from provider systems. We now have CDEX as an option for being able to integrate and grab clinical information from provider systems. So all these, and in conjunction with other kind of regulatory requirements like the payer-to-payer API, they kind of lend themselves to the introduction of a longitudinal member record that that health plans would use to kind of capture this information and build out this persona for their members. And so the more information that we get from providers, if we can come up with strong strategies for maintaining that information in ways that are usable, then we can apply that information not just in the electronic prior authorization process, but also across many other workflows within a health plan. And a lot of buy-in on the provider side comes from not having to go back to those providers and repeatedly ask for that same information. So you can take advantage of these new APIs and existing kind of data exchange functionality that we have here to build up that information for your member, leverage it to support that EPA process and reduce that burden, but then scale that kind of concept across other workflows and other processes within your organization. And so with that, those are our 6 lessons. We encourage you to visit our website, the links below, to learn more about how we're helping plans maximize their ROI on EPA. I think we're pretty good on time. We've left just enough time for a few questions. So I'll turn it back over to Chris, who will be our moderator for the Q&A.
Yeah, thanks so much, Stephen and Jess, for that wonderful presentation. Clearly, you covered a lot of ground that's going to be very helpful to everyone in the audience today and beyond. We do have time for questions, as you mentioned. We would encourage the audience, if you have not posted your questions yet, there's still time to do so. we absolutely encourage that. But to get you and Stephen started here, Jess, what we have is, it's a two-part question. Part of it asks whether this whole process should be accelerated with AI. They also want to know, are payers encouraged to do so?
So I think it's very important when you talk about AI. AI has applications on both sides where AI potentially could really, really help. So one is the attachments that providers have often have to supplement their prior authorization requests. I think Jess might have mentioned it at some point that under the current vision, that will be automated by using a query language called CQL, which will be able to query FHIR elements on the provider side repository. It is possible that all that unstructured data, instead of having to have somebody to more deliberately move it into FHIR, that could we have AI or Gen AI just read all that documents and actually translate it more fast into structured elements. So there's that possibility on the provider side. And you're right, on the payer side, there's questions about, can you speed up prior authorization by at least having a preliminary adjudication using AI, in light of some of the initial experiments. I will tell you, on the payer side, there is real concern about just relying on AI to make those decisions due to some of the drift and whatnot that you have in AI. So in general, there is tremendous possibility for AI to help on both sides. We're not there yet on either side. I think that we are going to be there a lot faster than we think, but we're not there yet. So it's not something that we're going to feel within probably the next 3 to 5 months. In terms of your second question about, do payers really want to do this stuff? And payers there's many different types of payers, and there's many different departments within payers. So and I am not the right person to speak on behalf of payers everywhere. All I can tell you is the personal experience that I've had. I know that Jess has had, that we've had as an entity. At least the health plans that we're working with, they really want to make this work. And they are really thinking about, as a matter of fact, when we go to talk to a health plan, we tell them, look, if all you're looking for is minimal compliance, I don't know if we're your best partner, but if you're really looking to leverage the technology being mandated by 0057, we want to work with you. And they are definitely making good on that commitment.
Terrific. Thanks, Stephen, for unpacking all that nuance. Clearly, there's a lot of layers there when it comes to AI. But yeah, the explanation is very much appreciated. The next question we have for you both is, leaders have heard that Blue Cross Blue Shield is using your technology to enable EPA, I should say, and how is it doing so?
Yes. So great question. We are working with Blue Cross Blue Shield Association on a national EPA solution to assist in the brokering of prior authorizations that come between home and host plans. So you can think of it as this massive network of integrated Blues plans that are sharing those prior authorizations, leveraging that IG to accomplish that, and being able to do reporting and metrics on those interactions. So we're very excited about that effort. It will be a great testament to, from our perspective, the scalability of an EPA solution dealing with the size and the scope of the entire Blues organization. But yes, we're very happy to be working with the association on that project.
Terrific. Thanks, Jess. So the next question we have is about enforcement related to plans supporting X12, and forgive me if I'm saying that correctly. There's an audience member who'd like to expand on that.
So this is X12 enforcement. It sounds, and whether or not, let's see, whether or not there's a requirement to support X12 or the deferment of enforcement of X12. So from my understanding, and I'm definitely not the legal expertise here, but from my understanding, with this, with the exceptions that have been put in place, there are options now to support FHIR-based and X12-based interactions for that path process. From our perspective, one of the main things that we were focusing on is making it flexible enough that folks could choose or be flexible with what format was used based on what provider system or what application was connected to that API. So I think that's really important when we're dealing with building out these interaction points, and it kind of speaks to that integration engine layer that has to sit in between the provider systems and then your backend systems to be able to either deal with FHIR as it comes in and translate that into X12, or simply to be able to catch an X12 document as it comes in. So I think at this point in time, there can be, one, the other, or hybrid models, but being able to support them or being able to kind of flip between them is critical from an adoption standpoint.
Yeah, so it's interesting. Weedy just did a survey about, who's going to use X12 versus FHIR versus a combination. So just to be clear, there was an exception. And again, we are not lawyers. You should consult with your own legal counsel, but there was an exception given that said by HHS saying that, for this, if you want to go the FHIR route only, that's fine. But the way we're building out supports both. And ironically, at least the survey data that I saw from Weedy, the respondents, it was the plan side that was more keyed on doing either and or both, a combination, whereas providers were tilting more heavily towards wanting to go the FHIR only route. But great question.
Excellent. Thank you, Stephen and Jess. That is going to be all the time we have today. Thank you for everyone for joining us today, for asking your questions, and certainly to Jessica and Stephen for their presentation and all the wonderful answers they gave. We also want to thank InterSystems for sponsoring today's webinar. Thank you again, everyone, for joining us, and we hope you have a wonderful rest of your day.
Thank you.